Welcome to the Healthcare Entrepreneur Chat. We're excited to be here. Unfortunately, our special guest today is still not arrived, so hopefully he'll join in the middle. But anyway, we were excited to talk about telemedicine and the challenges of entrepreneurship in healthcare. I'm your co-host, John Lynn, the founder of healthcarescene.com, and my beautiful, I'm not sure which direction you are. You're down? Okay. Our beautiful co-host, Melissa McCool's here. Welcome, Melissa.
Well, thank you, John. This is so fun. And we were going to be speaking with Jamey Edwards, who is CEO of a telemedicine company out in Los Angeles. But he is not here. We're not really sure what happened to him. He's probably stuck in traffic because he lives in LA.
See, now you're talking bad about it.
Blab. There is a Blab app, so I'm not sure that's a good excuse.
I don't know if they have good internet in California. But yeah, he's the CEO of CloudBreak Health, which, what I thought was really interesting, and I hope he makes it because, I saw the stats, and these are probably outdated stats because these stats on the LinkedIn profiles go out of date so quickly. But they actually are performing 60,000 encounters per month in telemedicine in over 500 hospitals nationwide, which I love when people say, yeah, when telemedicine becomes a reality. And it's like, well, 60,000 encounters a month means it's already happening. It already is a reality. So it's pretty interesting. The other thing about CloudBreak Health that's interesting, we'll see if he comes, but it was actually a merging of two leaders, a language access network, which does video remote interpreting, and then also telemedicine, which, it's interesting to combine those two of interpreting, which is so important in healthcare, especially at hospitals, and the telemedicine side of things. So we'll see if he makes it. But, we have so many people here. I mean, I just saw that Mohammed, better known as at mHealth1, just joined as well. So if any of you guys want to hop online, we certainly welcome any of you to join us and have a little conversation about the challenges of entrepreneurship in healthcare. Welcome, Gary.
Yeah, I'm accidentally disconnected. I put the link to this document about the socioeconomic impacts of screening.
Perfect. So before we started recording, Gary Levin, he was telling us about how they use telemedicine to screen in ophthalmology to see if people are at risk for diabetes or if they have diabetes. I can't remember.
If they have diabetes and they have to be screened every year before they develop some serious complication like a hemorrhage.
Right. So it's basically using telemedicine to screen to see if they have diabetes before, so that then you can treat it in early detection, it sounds like.
Yeah, well, if they're diabetic and they've been diabetic for 5 years, the American Academy of Ophthalmology recommends they be screened every year or two. But in this particular aspect with this company I work with, the business model was tricky to get because a lot of health insurance companies still don't reimburse for telemedicine. But this particular company really got on it and decided it was going to be cost effective to do it. And the business model we use is for our company to build. When they contact us, we build the company, and they pay the ophthalmologist through us. It's their business model. It's more efficient. Plus, their big data. Really, the insurance companies are the people that have the big data, so they can filter the thread to who has diabetes and who's not coming in.
It's interesting. I think we're just at the early stages of insurance companies being proactive in that regard. Sorry, what were you going to say, Melissa?
I was going to say, are they, for the ophthalmology, are they looking at the retina?
Yes.
Because I know they can look at the retina and see if someone's at risk for
I'll put another link in the thing here. You can go to the website.
Right. Yeah, no, I see that.
Go to our webpage here, and it actually shows that we have a couple little videos on there how we do it, and it's got the whole 9 yards in it.
You know what I'm really curious about is, are there any clinicians on the line, the providers, that have done telemedicine sessions? Because I have as a therapist, and it's actually, I found that providers have a hard time getting used to it. Because one of the problems is that when you're doing a session, you have to, like, where your eyes land is not where it looks like. You have to look up in the microphone. Otherwise, it looks like you're sort of off in the distance. And for psychotherapy, that becomes really important. So actually, I know quite a few providers who actually don't like doing telemedicine sessions. I don't know if anyone else has had that understood clearly. Oh, look at that. Jamey's on the line.
Jamey's here. So.
Yeah. So let's, you know what, Gary, do you mind if we put you off for 1 second?
I'll drop out. I just want to let you know what I had in my pocket here, okay?
Definitely. We'd love for people to hop on, hop off. I think that's the best part of Blab is the more people that hop on, the better.
Yeah, because I know Mohammed wanted to jump on real quick. Jamey, would you like to jump on as well? Because I know Jamey is there. Hey, Mohammed, how are you?
Oh, we don't have any sound for Mohammed. He must be muted.
Yeah, we can't hear you.
All right. Can you hear me now?
There we go. Yep. How are you doing?
Good, thanks. Thanks for having me. Thanks for having this Blab.
Yeah, definitely. It's always amazing who shows up. We love people coming the first time. Experience the fun of it's like a mini hymns, but online.
You know,
so
you brought up a good point about how to properly use the technology because of the camera location. You know, what I would call the proper etiquette of telemedicine. You know, that's something that as we develop this technology is coming out, some of that etiquette is being evolved. But telemedicine and healthcare has been around for years because technically tele is just, you know, something remote. And we've been doing remote monitoring since the 70s. You know, if you think about telemetry, you know, just looking at people's EKG. So we're just adding different variances and different models to that care. First, it was just within the hospital system, and now it's becoming more accessible, kind of like what I call the urgent care visit. You know, instead of having to run to an urgent care, you can just call up a doc that you know, or like you did, John, cut your toe off.
No, you're right though. There's an interesting etiquette that, you know, it's almost like its own culture that has to be created around what's appropriate, what's available, what's good. That's a good discussion.
And yeah, no, it is, and especially depending on your specialty. But anyway, we won't go off on that tangent. Jamey's here.
My sincere apologies. I was stuck in a meeting with a client, and I'm like, I have to leave. I have a blab. And they were like, what are you talking about? So I'm here. My apologies to everyone, and let's blab.
The crowd stayed, so we're excited you could make it. We did a short intro just talking about CloudBreak Health and some of the work you're doing. So definitely, and we're glad Mohammed's here, and definitely stay on, Mohammed. But we can rotate people through if other people want to hop on as we discuss.
I'll hop off and let some other people join on. Thanks, guys.
Good to see you, Mo.
That's good.
So, Jamey, do you want to give us those watching maybe a little background on yourself and your experience and your story and how you got into telemedicine as a company?
Yeah, how much time do you guys have?
Till 5.
It's a little bit. So, really quickly, my background was in investment banking and private equity. I actually worked at Lehman Brothers and their communications and media group, but had been doing some consulting for a company that was actually founded by my uncle. So yay, nepotism on your first CEO job opportunity, right? And he ran an ER group, a small little ER group in Southern California. And I'd been doing a ton of consulting for him, helped him move out of his home office to a real office, built all of his infrastructure in Excel, and taught him how to speak about things like revenue and EBITDA. And eventually, the company grew, and it went from 1 site to 2 sites to 3 or 4 sites. And he said, you know what, Jamey, I need you to come full time. So I left my banking and private equity career to go take the helms of a small little ER group that no one knew about in Southern California. And really haven't looked back. It was a great learning experience. I was at EMA, that's the name of the company, Emergent Medical Associates, for 10 years. And we grew the business from a $12 million company into a $150 million business over the course of that time, and expanded from just ER to ER hospitalist and anesthesia. So a true multi-specialty group. And so I really learned healthcare from the bottom up in working with him, and learned about, different healthcare technology that people would come and actually pitch us on as ER physicians and hospitalist physicians, but really learned what the three primary focus points of a hospital were, which were, patient satisfaction, efficiency, and financial performance, right? When you talk about kind of triple bottom line type stuff, and really took all that knowledge that I learned about Emergent Medical Associates. And back in January of 2008, Language Access Network came seeking an investment. They were a video remote interpretation services company. So hit a button on the screen, get an interpreter in 250 languages, 60 of those in video, the rest in audio. And so it was really a gateway telemedicine business, if you will. And it was kind of how everyone got used to telemedicine from an enterprise standpoint in the hospitals. And so took over as the CEO role there while I was doing the CEO role at EMA as well, and did that joint role for about 5 years.
That might be a good thing to discuss later.
Yeah. Happy to talk about that. But we really refounded a telemedicine business within this other healthcare business. And eventually, we sought to grow that company, and we went out and did a funding round. And part of the terms of that funding was that I would take over the CEO role full time and really just focus all my time and attention on building out that business. And so, Language Access Network since January of 2008, since I joined, grew from 10 clients to around 500 across the country. We're currently doing 60,000 encounters a month over the platform, which makes it really one of the largest telemedicine companies in the country by numbers of encounters. If you compare us to someone like Teladoc, they're doing 100,000 a year. We're doing that in a month and a half. So really, really kind of proud of what we've built. And back about a year and a half ago, we said, you know what, the language services business on its own, we kind of treat it like any other ology. So neurology, cardiology, language services, think about it as languageology, right? It's just another service over our platform. And we said, let's split the platform out. And the way that Language Access Network connects to its hospitals is over its own private broadband network. So over the course of the last 6 or 7 years, we've built one of the largest private broadband networks connecting hospitals to each other in the country. And we said, you know what? That business needs to focus on being the best telemed platform it can be, while language services focus on being the best language services platform. So we created CareNection, right? And so we have these two separate companies, CareNection and Language Access Network. And, Language Access Network is merely another ology on the CareNection platform. So really proud of what we've done. And as part of the financing that we did, we put an umbrella company over the top of both called CloudBreak Health. And so CloudBreak now is really a telehealth enablement platform that integrates one of the leading telemedicine platforms in the country with language services. And you can do this all on a single call. So the main pitch is unify telemedicine in hospitals, right? So if you walk into a hospital today and you want to use their telemed platform, and you have a Spanish-speaking patient who wants a telepsych consult, you need to roll two separate devices into the room. And we just don't think that's all that collaborative. So it's all about one device, one platform, all the specialties you need in one place.
And is that what most of your visits are? Is the translation services and facilitating that, or are you doing others that don't use those interpretive services?
Yeah, so right now we're launching our first teleneurology program with a major academic institution in Southern California and a local community hospital. We're launching our first telepsych programs, all using the same platform, same technology, same backbone. So it's now a multidisciplinary approach.
Wow.
It's pretty impressive what you've been able to do.
It's been quite a journey. It's been quite a journey. We had the moments very early in our career, as you do with any technology, where you're like, we really hope it works when they hit the button. We've worked through a lot of that, and now are the enterprise telemed providers to the hospitals that we serve.
Did you have a lot of times where you said, I really hope that happens, and then it didn't?
Yes. As with any cutting edge technology or pioneer in the field, you're going to run into those situations. All you can do as a company is own it and help to solve it. And I think we actually generated a lot of goodwill with our clients by really digging in side by side with them and being very upfront that, we're trying to solve these problems. And, it's a very complex thing because you're not only trying to solve the basic problem of, one, the connectivity to the hospital, but you also then need to solve the problem of the hospital's network. And every hospital's network is configured differently. And you need to work through all of those issues on a very localized basis. So we have a very big partnership with IT, who's a key part of helping us deliver our service, and that makes their life better and more efficient.
Wow. Well, what would you say right now is the biggest challenge facing telemedicine in general, just as a kind of broad category? I mean, in terms of moving it forward, not just your company, but just sort of in general, what's the biggest barrier or obstacle right now?
Yeah, that's a great question. I think one of the things that we see in the market all the time is that we in healthcare think we're different than other industries. And so people take a look at these types of video technologies and they're like, well, this won't work for the following reasons, or we can't do it because we feel like it compromises patient care, when all the data actually is to the contrary, right? It increases access. Rural facilities who don't have access to top-notch neurologists can now have, a Mayo Clinic stroke consult, right? How amazing is that? And even in urban facilities, there are a lot of urban facilities that have problems filling call panel because their hospitals are treating a lot of Medicaid and underserved patients, and they haven't been able to attract doctors to their medical staff. This helps level that playing field and really helps get rid of the healthcare disparities, if you will, that might exist between underserved populations or rural areas. And so the biggest challenge is changing our mindset in healthcare, and that, we tend to be a little bit fearful of these innovative products that come down the pipe and want to find all the reasons why they won't work instead of focusing on the reasons why they can. And that's really been what we've been doing for the last, 8 years, has been focusing on that missionary kind of storytelling in the market and showing people that this really isn't new and innovative care at this point. It's just the new healthcare. And we should be referring to it as just healthcare. And it's just the most recent modality of how we deliver it.
Right. I wonder, again, in a way that it's the people who might be putting up barriers. Do you think it's the payers or the providers or the patients, or it's just system-wide? Because I've noticed, we were talking a little bit about telemedicine etiquette, and I've definitely noticed with providers that there's a real, I don't want to say resistance, but there's some reticence to doing it because just getting used to seeing patients in this way. There are certain providers who are not, the early adopters are fine with it, but I've seen the resistance with some providers. So what do you think it is? Is it a combination or?
Yeah, I think it's definitely a combination. Although I'll tell you, most patients, their reaction is cool, right? I can access my doctor from my home, or wow, I'm looking at a language interpreter over a screen who's located and it allows me to speak to my provider. Most of the patients' reactions that I've seen is cool. Now, they might not want to be the ones who, from a B2C standpoint, if they're the end consumer, as opposed to the hospital who uses it as a tool within their toolkit, they might not want to be the ones who are saying, well, you know what, I'm going to call a teledoc. And they may still find that to be a somewhat challenging experience. Although I think companies like Teladoc and MD Live and Doctors on Demand, are doing a pretty good job of bringing high quality physicians to market. So I think we're going to continue to see that barrier drop. But, insurance companies, well, they're the ones who are handling the reimbursement, right? So until they realize that, and I think a lot are now, I think you're seeing an inflection point where insurance companies are finally saying, if you look at companies like Oscar, right? Who's a new and innovative insurance company, they're saying, well, look, telemedicine is part of our delivery model to delivering value to the patient. And the biggest challenge right now is absolutely kind of in and around the acute care environment in hospitals and changing the provider mindset, who says, well, no, I'd rather have someone here in person, or I have to touch and feel the patient to make that diagnosis. And I think there's a lot of legitimacy to some of those concerns, but they can be worked around with proper workflows, proper policies and procedures, and proper escalation methods. So, again, it's an efficiency. I would challenge people to find another tool in a hospital that handles as many pain points as telemedicine can, from a quality standpoint, from an efficiency standpoint, and actually from a satisfaction standpoint as well. doctors, when they realize they have backup, even if that backup is on video, if you have an ER doctor and he says, well, really, I think we might have a brain bleed there. I really need to get a neurologist in here. He's going to be pretty excited to be able to bring that neurologist into the conversation, even if it's over telephone.
Right.
Nice. Welcome, Mohammed. I don't think we can hear you. Yeah, did you have a question or a comment you wanted to make?
By the way, this blab thing while we're waiting for Mohammed, very, very cool. This is my first blab, and I haven't experienced it before. And this is like,
it's free telemedicine if you get the right doctor on here. You know, you can get a telepsych consult if you get Melissa talking the right way. But
there you go.
You could all be on the couch. You know what's cool? Did you guys watch Brady Bunch? I always think of Brady Bunch. We just need like similar things, and we could be. I could be Jan or Marcia. You could.
I think it feels more like Hollywood Squares, but there's no center square, unfortunately.
Well, we
still can't hear you.
When we bring on multiple physicians into one call, they have this view, and we refer to it as the Brady Bunch stream, right? So you've got, Melissa would be Dr. A, right? And you would be Dr. B, and we'd all have this collaborative conversation this way. I mean, look, the fact is the tech works well, right? And you could see treating a patient this way. And the one thing that we're working on at CloudBreak, which I think is really cool, is something that we're calling needs-based viewing. So what does the patient need to see versus what does the doctor need to see versus what does the doctor on the video end of the telemed call need to see, and coming up with their local views and saying, you know what, they need to have customized views that suit their purpose. Because, clearly the patient doesn't need to see the patient record on the screen per se. They need to be seeing the interpreter and maybe the physician. And so working on that and making this more of a seamless experience is something that we're very focused on doing.
Hmm.
No, we can't hear you now. It's like a Verizon commercial.
They're our next sponsor is Verizon.
Yeah.
They probably don't want to sponsor if you can't hear them, though. So, yeah, I think that it's interesting. So far when you've talked about telemedicine, I think you come from a very hospital-to-hospital focused perspective because that's what you've built and that's the network you've created. And even just hearing you describe it, you've described the challenge of every hospital network is different and unique. But if you extend that further, Mohammed is outside and he would love to do a telemedicine visit. Now you just added like an infinite, what is that, an order of magnitude more complexity in environments, maybe 2 orders of magnitude more complex. So is that why you haven't focused on it? And yeah, we can't hear you, Mohammed.
Hey, Mo.
Technical problem.
They don't have those at Jamey's company, but is that why you haven't focused on the direct-to-consumer, Jamey, or do you think
the last mile problem, to your point, still seems to be an issue, right? What do you do when you're trying to do a telemedicine consult and your son is downloading the latest movie from Netflix while your daughter is doing X, Y, and Z, right? And taking up all that bandwidth, and it's very hard to control that. We have our own broadband network because we can control what's called quality of service over that network. And we can prioritize the video signal over that network so that we know that, you're going to have less packet loss, less or higher quality, a certain number of frame rates per second to make that video signal as good as it possibly can be. We're currently working on with Verizon and with AT&T coming up with what's up? Okay. We are currently working on coming up with a similar service over cellular that might help us solve that last mile problem. So those are the type of things that really get us excited, is when we can have the same quality for in-home health telemedicine or on-the-go telemedicine as we can for what we're doing in hospitals today.
So I'm sorry, I don't want to take a lot of thunder, but I do have 2 people that are on 2 phones waiting. There's one question that they have, right? So the notion of bringing in medical interpreters into a facility is just, that sells by itself, right? So you got people at medical interpretation. So as we bring in, the main question that I'm being asked all the time is, what kind of training do you guys provide?
Yep.
So it's like, well, we're going to hear it from him thanks to Melissa 7. So tell me, what kind of training? I got 2 people waiting, one from Mexico and one from Dominican Republic. So
all right. Well, let's speak to the world right now.
Guys, you should be in Blab too.
Yeah, our interpreters are certified medical interpreters. Anyone that we hire is either already a certified medical interpreter or they're on the path to certification within 6 months of being employed with us. So it is the highest, the highest kind of measurement of interpretation you could possibly have in healthcare. So certain companies have qualified medical interpreters. That's not the same as having a certified medical interpreter. So there's a ton of testing, a ton of continuing education that we do on a regular basis. And all of our interpreters from a video side are located in US-based language centers. And that's important because, and they're all W-2 employees, so they're not independent contractors. So we can give them more training than any of the other folks in the industry. They're in an environment, we've really tried to create the Google of interpreter services companies. So they have a place to come to every day where they can be, we have the most international environment in our offices that you've ever seen. We kind of joke that our annual, we don't have a Christmas celebration. We have a celebration of success. And it's because we have so many different cultures that the potluck dinner there is really something to behold. We'll invite you guys once, but it's literally, we have food from 40 different countries, right?
Wow.
At any given time in our language center. So it allows us to attract the highest quality of interpreters. A lot of our interpreters and their stories are actually really amazing. They might have been a doctor in another country. They still want to come and work in healthcare, but they're not licensed to practice here. So we'll train them as interpreters, get them certified. And wow, what a great person to have as your language services advocate when you're going through an acute care, experience here in the health system. We have American Sign Language interpreters. They're all RID certified. I mean, you will not find more highly trained interpreters and more highly supported interpreters than the ones at Language Access Network.
I clap to you because I pretty much just fulfill all of the gaps that my teams, because both of these are my clients that subsequently are going to be your clients. So that's pretty much the main question that we were trying to address, right? Whether or not they were going to be using like a call center versus a real medically trained interpreter. So, Jamey, thank you so much, Melissa. And I don't know if you want to go by the tech guy or you rather use your real name. But,
the name is not mistaken.
Absolutely. And Jamey, I know that you got like probably a whole bunch of texts, including mine, to kind of get in here. So sorry about that.
Yeah, no worries.
All right, let me let somebody else talk. Thanks.
Thank you. That was great.
That's great.
Somebody.
The interesting thing about the interpreter is, like, I love the stories that come out of the use of the system every day. When a patient is first heard and first understood, being in a hospital is scary enough when you speak English. When you don't, right, it's absolutely terrifying. And you have people running around and hearing the stories that come out of a provider who doesn't have to practice what they call veterinary medicine because they have to do a bunch of tests on a patient they can't communicate with. Or, just a patient who's been understood and what a satisfying experience that is for them and how we've been able to reduce their anxiety. That stuff's happening every day in our language centers, and it's really gratifying.
Someone is asking your opinion whether you think telemedicine can replace human interaction.
You can replace human interaction. You know what?
Yeah.
I think telemedicine is human interaction, right? We're all humans on this call. While we might not be in the same room together, there's a bond, a rapport, a communication that's happening because 70% of communication is nonverbal. Right? All the studies say that. So being able to see your face, Melissa, right, and you, tech guy, right, see the smiles, right, all of that makes a big difference. Like if you're talking to someone on the phone and they're like, "Oh, I'm having chest pain," but they're really grabbing down here. Hard to see that over the phone. So you end up having to ask a lot of clarifying questions. But over telemedicine, you can see it. So I don't think I think telemedicine will replace it for lower acuity cases. But as you move up the acuity scale, I think there's still a huge role for that in-person acute care setting or the retail clinic or the urgent care center because certain medical diagnoses require hands on the body and, being able to do diagnostic testing. And by the way, telemedicine is getting much better with diagnostic testing right now with all the peripherals that can be plugged in, pardon me, to a telemedicine card. So we're getting better on that front. But no, I don't think it's necessarily going to replace it. I think it's a great another arrow in the quiver to help us match cost to acuity of a condition.
What's your answer to that, Melissa, from a kind of, psychologist counselor perspective?
Well, you know what I was going to say is that I think that was an excellent answer, Jamey. And it's funny because my first reaction when I saw that was, well, of course, is that me? Sorry. I was thinking, of course, it can't replace in-person interaction. But as I was listening to you, I was realizing you're absolutely right. Insofar as most people are visual. So being able to see, that's much better. Being able to see someone's interactions and the very subtle cues by looking at them, it's far superior to the phone. However, what's interesting from a therapist's point of view is that when you're doing therapy, you want to be able to pick up on the emotions. And and it's so curious because I don't know if you would be able to pick up on, because emotions are contagious, but I don't know if it's because you're literally physically within close proximity to someone, that if someone's sad or angry, if you're a sensitive person, you pick up on it. I don't, honestly, the few sessions that I've had as a therapist, I haven't been able to pick up on emotion as well. That was my problem, and because it can be diagnostic as a therapist. So to me, it's not quite. But having said that, when you think about the convenience and all the other things that you get from it, and so anyway, I just think that's fascinating.
I would add two things. One, you try to do it over DM on Twitter, so I don't think it, you're inhibited. But the second is, I think a lot of it is, if the question is, do they get any help, or do they get help through, do they get any help and do it through telemedicine, or the alternative, which means that they probably get no help because they chose not to go in. Then the answer is it's much better, right?
Absolutely.
Yeah. And John, kind of to your point, at the end of the day, we've all been trained in the analog world, if you will, right? Mm-hmm. And so maybe, Melissa, it's that we need to come up with a training so that you can sense those emotions over telemed, right? So I can see you and see those cues. And maybe we just need to get more experienced there. And it was actually interesting. If you look at some of the research around IBM Watson and artificial intelligence and people's honesty with someone in the room versus them not being in the room, or honesty with artificial intelligence versus a real person, you'll see that people are more honest when they don't have a rapport sometimes with someone, which is a really interesting counterintuitive thing that I wouldn't have clued in on unless someone had told me. I just thought that was interesting, right? That someone might be more honest with artificial intelligence about their condition because they're not going to suffer any embarrassment from it than they would with a real person.
Yeah, no, you don't have the shame there. And there's a sense of sort of anonymity. It's the same reason I think there's been a little bit of research on like texting, that people, when they have sort of texting relationships, they get much more intimate more quickly because it almost feels like you're just sort of throwing it out there. It's almost like writing a letter to some extent.
Right.
So I think that the idea is there's not the immediate feedback. I don't know. It is, it's fascinating.
Well, it's interesting. It's almost like, Melissa, like what's the right level of distance to optimize the connection versus the disconnection that gets you to the most honest broker dialogue you could have, right? And I think that's going to be an interesting thing to look at over the course of the next few years is what is that optimal distance? Because it might not be face-to-face with a person in a room. It might be, oh, you know what? I want to see someone, but I don't want them invading my bubble per se. And that's going to make me more honest. It'll be interesting to watch. And you're going to be on the forefront of this.
That's true. I mean, Blob I'm still going back to the fact that, what we're doing here is essentially could be telemedicine if it was just done in a little bit more private way. Yeah. And we're all doing it. And, we've run around the country. I mean, Melissa and I have done ones with people from Sweden, from Ireland, and it works exactly the same way. We've had people from Saudi Arabia or from the Middle East join us. It's powerful. Let's see if Mohammed works.
Another assumption, right, is privacy.
Yep, you're good. So you're talking about privacy?
Yeah. So it's like me was a really great source and website that,
Mohammed, we just lost you, man.
helped.
Mohammed.
Live by the tech, die by the tech. I guess in healthcare, we better be careful saying that. In telemedicine, literally someone could live by it or die by it. So maybe I shouldn't say that.
Yeah, well, I'll tell you, more people are living than dying by it. The number of, if you take a look at a company like Specialist on Call or whoever it might be, if you take a look at the number of lives that are being saved by telestroke and teleneuro programs across the country, it's staggering.
Yeah. No, I'm sure. Hey, John, we can only hear your audio. Jamey, what I was going to say before, what's really interesting, I look at this, hey, Michael, I look at this and I think, wouldn't this be fascinating, like group therapy as well?
Yeah.
Sort of the dynamics, like, anyway, only 4 people, but hey, John, we still can't, now you're totally gone. Hey, Michael, how's it going?
Good evening, everybody. Could you hear me okay?
Yeah.
No, you're good.
Excellent. Sorry, I guess was disruptive earlier. I apologize for that. Jamey, nice to see you again. Oh, hey, John, don't leave on my account. I don't know where you went. So, Jamey, I talked to Bill today, and we had a really good discussion, and hopefully get out there to see you guys in Columbus one of these days.
Yeah, anyone that wants a tour of our language centers, which we're turning into telemedicine centers, absolutely feel free to let me know. We're currently in the process of building one out in El Segundo, California, where I'm based. It's done behind me. But the main one's in Columbus, Ohio. And anytime anyone wants to arrange a visit, we're happy to walk you through it.
That's great, Jamey. And we had a great conversation, you and I, as well as with Bill today. And I'd like to get your perspective on where does telemedicine, I guess, impact or leverage analytics, big data analytics, in new and different ways that can bring more encounter data to each patient, bring more context to each encounter, if you will, and how does that work over a system such as yours or whatever the platform may be to actually consume that data and make it more actionable, and if there's a way that's different than a live visit.
Yeah, I mean, that's kind of the problem with big data, right? There's almost too much of it. And how do you turn that data into an insight that then you can take action on? That's kind of the holy grail of big data. Well, look, I think the more that we implement these new technologies like telemedicine, like we're recording this blab right now, right? So could we put this blab through an artificial intelligence engine and have it then discern for us the main topics of conversation, what we thought was important, right? So on and so forth. I think those same capabilities exist and in appending the patient visit to, the EHR patient record, and then running that through artificial intelligence and trying to discern different physicians' practice patterns, and saying, okay, well, look, we're going to look at the following chief complaints. Why did Dr. A treat it this way, Dr. B treat it this way, and Dr. C treat it that way? And by the way, which one had the best outcome, and which one had the best satisfaction, et cetera, et cetera, et cetera. I think technologies like this, will help us measure those things. And I think it was Peter Drucker who said, what gets measured gets managed. So having the data is part of the first part of it. And then I think you start integrating things like wearables. And I think it was Jay Sanders, the grandfather of telemedicine, if you will, or the father of telemedicine. I don't want to age him out too early. But he basically, went through and said, if you can measure all this data, that most of the data that's relevant to your health happens outside the hospital, right? So what's your resting heart rate? What's your average, not the average that we will attribute to a population, because everyone's body is different. And one of the most damaging things to healthcare over the past, 20, 30 years has been us applying averages in terms of ranges for diagnostic testing, whatever it might be, to someone who might have a unique situation. Michael, you might have a resting heart rate that's higher than the norm, and that's how your DNA is, and it works for your body. And who are we to apply an average to that and then say that, your heart rate's too high, right? As an example, we should be doing, longitudinal data studies and trends on what each of our baselines are most of the time. And right now we're doing it, and we're only doing it for when we're in the hospital or in the doctor's office. So I think when you mix wearables with technology around the patient visit, the people who come up with those algorithms and those filters and those visualizations that really help people understand that data, I mean, that's going to be a big deal.
It's exciting. So
yeah, absolutely, Jamey. Yeah. Go ahead, John.
No worries. We only have about 5 minutes left. We try to keep these to an hour, and unless Melissa wants to hang out. But with the last 5 minutes, I'd love to hear some maybe entrepreneurial stories or insights, suggestions you have for other entrepreneurs that maybe are a little farther behind. Because you're pretty far along in this journey that you've taken. I saw something there, 3-time honoree for the Ernst & Young Entrepreneur of the Year award. So. We should learn a little something from you about entrepreneurs. So, any stories, insights, anecdotes you want to share?
Well, I think it's an interesting question. I think either entrepreneurs are, we're just risk averse or we're dumb. I can't decide what it is because when everyone else says, no, you can't do that, we kind of step in and say, oh, really? Watch me try. And you have to accept failure as part of your culture of risk in terms of building any type of business. And you have to be okay with getting the calls and everyone saying no to you, which, by the way, at times is like totally demoralizing. And you've got to like power through that. I think one of the things that's been really helpful for me is I've done a lot of mentoring at an LA incubator called Start Engine. And when I was in business school, I sat on our school's venture fund as one of the partners of the venture fund, reviewing deals. And clearly I have a little bit of a deal mentality. So I've developed this ability in life to kind of say, this is going to work, this isn't, which one do I really want to place my bets on? But at the end of the day, the guy who started FedEx got a C+ on his, I think it was actually a C- on his business plan at Yale. So, if you really believe in something and you have a different worldview, go after it and don't take no for an answer. Because all those ideas that people thought were dumb are usually the ones where people have been really, really successful. I also think as entrepreneurs, there are very few Elon Musks out there who have been able to replicate their entrepreneurial success to the degree that he has. I mean, you have to have mad respect for a guy who's taken on the automotive industry, financial services, space, right? Yeah. All of these, and energy. All of these industries that are thoroughly entrenched. You need to have a ton of money to go after them. And he's really put it all on the line, right? I mean, he... very realistically, he said, was sleeping on people's couches for a long time, but he was a billionaire, right? And it's because he really placed his bets. So you got to believe in yourself, believe in what you're doing. I think, there's smart ways to enter markets that are in chaos where there's opportunity. I think healthcare obviously is one of those markets today. There's just so much innovation, so much change, and so much desire to change. That there are a lot of people coming in from all different angles where we're starting to finally attract, I think, really great innovators of high quality to healthcare and health systems. I mean, to see some of the work that's happening at places like Intermountain or even Kaiser, they're doing some really innovative stuff and they're making investments in UPMC, Raju Sesma, right? I mean, he is, they're actually putting money to work in companies that they believe are going to be really successful and where they see a lot of value. So, I think it's easier than it's ever been to be an entrepreneur. The barriers
it's still not easy.
But it's still not easy. But the barriers are lower than they've ever been, right? Like, how much does it cost to build an app these days, right? If you really have an innovative workflow and something you think is going to be valuable, it used to probably cost you, you're like, well, if I'm going to start a business, I need VC funding. Well, now you're kind of like, well, I really need 50 to 75 grand. If I can make that happen and I'm willing to get my family to invest in me and get some friends to do it, then I could really make a go of this and start it. And there are more resources than ever at entrepreneurs' fingertips. So yes, still really hard. I think the barriers are lower than they've ever been, but still very difficult. But, if you have a dream, I say pursue that dream because, I'm much happier being out there and running after what I'm passionate about than I would be with a really good corporate job,
It's interesting that you brought up Elon Musk. I heard one of his friends tell me a story when he was just starting the SpaceX stuff and he was just starting the early Tesla stuff. And he said he literally was sleeping on his couch in New York City and he was about to have the launch of the rocket. And he said if the launch of the rocket failed, then Elon Musk would essentially be bankrupt.
Right.
And he was going through this stress of, I may go from being a multimillionaire, I can't remember if he was a billionaire at that point, but certainly hundreds of million, to having nothing and being literally with nothing, based on if that rocket took off or not, and how it went. And he said, you realize at that time that he'd risked everything for that. And it was a scary time, but so it's like it's fun to see him now and say the romantic. Oh yeah, he risked everything and he won, right? But that rocket could have just as well exploded, and and he would have had to figure out something else. But
look at their latest triumph, right? They're going to be launching the latest rocket out of Cape Canaveral. I think our friend Nick Adkins is actually going to potentially be there in person. I mean, that's some really cool stuff, right? And his goal is to colonize Mars. And I tell you, I think the guy's going to do it.
He's something else.
Yeah.
And I think one of the things I think that John and I have spoken about it a lot is actually the part when things are going down, things are not sort of looking so good, and you've taken a lot of risks and they're not coming to fruition and you're not getting the deals. What have you done that's been helpful? Like when the chips are down, because it's great to say, look, you have to take the risk and you have to keep working, you have to believe in yourself. But at what point do you fold, or at what point do you say, okay, I need to kind of shift my thinking about this, and how do you kind of put one foot in front of the other? Because I think when people are trying to start something new, I mean, just the risk, it's not just financial, it's an emotional risk because it's very destabilizing. So any thoughts on that? Words of wisdom?
Yeah, and by the way, those risks more intense. I'm getting some echo now. Those risks get more intense the farther along you go, right? When you have a family, you have kids, and you have a mortgage payment, and all of a sudden you're like, all right, well, what's my calculated risk here, and what can I put on the line without losing everything, right? And those are very personal decisions to make, and everyone handles it differently. I tend to really compartmentalize things, which is either a good thing or a bad thing. But I can have a failure in one space and learn from it, and then apply that knowledge somewhere else. And I think that's really what I've done. Anytime I've hit that failure, I've said, all right, well, great. I gotta cut my losses here on this one and move on to what I think that next opportunity is. And by the way, what did I really learn from this? And what mistake am I not going to make next time? But it's a very fluid process. And I'll tell you, every entrepreneur is different. There are some guys who their first time out, they hit that $1 billion business. And I think I might have mentioned this a little bit before. Yeah, I think as business people, John, to your point, we rationalize our luck, right? There's a lot of right market, right place, right time, right client signs on, right articles in Fast Company, right? Whatever it might be that builds to your success. And there are very few guys like Alon, which is what I was saying before, who have been able to replicate it. So you'll end up with guys who might have had one big success and every single thing they do after that is a failure. Or you'll have a guy who every single thing he did was a failure until this one moment, right? And he sees this moment.
And then you only hear about the one moment. You don't hear about all the failures. I mean, KFC is famous for that.
Yeah, and it's very much for any company, 10 years to an overnight success. Language Access Network was founded in 2003, right? And when we got involved, it was very close to failing before we turned it around. So, there are definitely a lot of nail-biting moments along the way, and you've got to be able to tolerate them. And I think, Melissa, to your point, you've got to be able to know when to call time of death, right?
So I actually have to cut out, but Melissa's going to carry on. You guys can stay, obviously, as long as you want. But I want to thank Jamey from my side. Love the insights. Certainly come back and join us at Healthcare Entrepreneurs anytime with any of the guests. I love your insights, and we'll have to check you out in LA or Columbus when we're there.
Yeah, anytime you guys want, that's great. And again, sorry for being a little bit behind, but thanks for keeping the blab open.
Right. Luckily, it's open. So I mean, there's so many people. You guys don't need me. I mean, you have Melissa. So yeah.
Bye, John. We'll see you later.
Hey, Dennis.
Hello. Question for James. I'm calling in from Howard County, Maryland. And one of the neat telemedicine opportunities that we're seeing here in our county is actually telemedicine at the school site.
Yes.
And the neat thing is that it incorporates the physician, the student, patient, with a school nurse. And the neat aspect is that the parent can also be part of that three-way telemedicine visit.
Yep.
And in many cases, the parent may be at work or offsite, obviously not at the school. The child gets the care that's necessary. It doesn't require the parent taking time off to go to the visit with the child, and there's that immediacy. I'm wondering, are you hearing and seeing this mode being used in other parts of the country?
Yeah, so we actually, as a company, work with the Horizon Foundation in Howard County. I don't know if you're familiar with those guys, but related to Johns Hopkins, they're actually one of our clients as well.
Okay.
So on the school side, we've actually heard about your program a lot, and it seems like it's going to be a very, very interesting opportunity. We're actually talking to a hospital in Hawaii right now about a very similar program. And the school market presents a great opportunity, right? Being able to bring everyone into one care portal, if you will, from the parent to the nurse to whatever specialist they might need, is a great use of the tech, right? And being able to, because there's a lot of stuff that happens at school, whether someone falls and might have a bad cut or bruise, or there's a sickness going through the school and people don't really know what it is and they want to be able to nail those things down. It's great to have that first touch point at the school itself with greater capabilities, because I'll tell you, a lot of the school nursing offices right now are just very limited on what they can do and what they can deliver. So getting all the support to those kids in a timely fashion is a great use of the model.
Good, thank you. And also, I'm familiar, the University of Maryland is using telehealth to monitor. I think there are over 225 beds throughout their system. So whenever you're talking about telemedicine, is it an outpatient setting? Is it a hospital setting? Is it telepsychiatry, teleneurology? And I'm a big fan of Jay Sanders, and I believe it's medicine being delivered over a video and audio connection. It's just medicine.
That's right. I couldn't agree with you more. Look, it's kind of all of the above. The use cases for telemedicine are just as plentiful as the types of medicine being practiced and the environments in which they're practiced, right? Telederm is something that's really coming on actually very strong right now. A lot of the use isn't necessarily synchronous, it's asynchronous. So it's store and forward type of telemedicine, as opposed to all of us being on the phone together. I would record something on my skin, send it into the doctor would review it, and then video voicemail me back or leave me a message, right? Right. There are a lot of opportunities like that in the market, and whether it's that or it's telepsych, teleneuro, telecardio, there's multiple applications. We're actually working on a model right now for digital scribing in hospitals. So instead of, are you familiar with what a scribe is, Dennis?
Yes, my daughter was a scribe, and now she's working in the emergency department where she was a scribe.
Oh, perfect, right? And that's typically what you get as scribes. You get these medical students who want to be in that environment and learn. But what we realize is that, they could see a lot more patients if they were in a language center or call center or scribe center environment, and that they actually don't need to be sitting there with the doc in order to scribe the chart. So can that be done using telemedicine? Absolutely, it could be. There was we just went to a CMO, CIO, CNO summit in Las Vegas, and you couldn't believe the ideas some of the chief nursing officers were coming up with that were great. And one of them was, wow, there's a huge shortage. I'm probably laying my whole playbook out there for any new startup who wants to get into any of these businesses. But if you have, there's a huge nursing shortage, and all of the nurses who had come back into the workforce when the economy went bad, from a baby boomer standpoint, are now kind of aging out of nursing, and they don't necessarily want to have the intensity of practice that they had before. And so what you have in hospitals is a lot of well-trained nurses who are still green, right? And how great would it be if they had nursing backup available via telemed? So if they had a difficult needle stick, or they had a situation that they weren't trying to handle, they could have, charge nurse on the push of a button who could support them in their decision making to making sure they make that good choice, right? We're always telling our kid, make good choices. It's the same thing for anyone who's new to a job. How do we get them to make those good, intelligent choices? And telemed is a great support mechanism for that.
I agree. And Melissa, I believe, and James will back me up, that telepsychiatry was one of the very first uses of telemedicine. And so I think it's a perfect fit for what you do so well.
Yeah. Yeah. And I will tell you, it's probably telemedicine's, top 1 to 3 use cases is telepsych. The fact of the matter is ERs really need it in a big way. They have people there in the ER who are languishing in a bed on a 5150 hold. And it's kind of like, great. Is that the best use of the bed? But what a bad experience for the patient to be sitting there just waiting to be discharged or to receive the proper care. And telepsych in acute care environments is hugely, hugely beneficial. And I think the thing about telepsych is, how come when we go to our physician these days, a psych eval isn't a normal, or a mental health evaluation isn't a normal part of a checkup, right? There's a stigma that seems to be associated with it that really shouldn't be there. And it should be a normal part of our health is our mental health. And I think because we've ignored mental health so much, you end up with a lot of acute care cases that end up just being mismanaged down the road because no one's managed the mental health early on. And so I think there's a huge opportunity, and telemedicine makes that all the more accessible.
Mm-hmm. It's funny, not to go off on a tangent, but I have my own little theory about that. If we put aside telemedicine for a second, I think that the reason people don't get the help they need is actually the term mental health. And I know that it evolved because instead of, prior it was people are crazy. And so, no, they're not crazy. They're just dealing with health issues that are mental. But I think the term mental health and mental illness is a problem now, because when people have symptoms of depression or anxiety, they don't want to feel like I'm not mentally ill.
Right.
There's nothing wrong with me. And so I think that actually the term has become, not a big part, but a small part of the problem. Instead of just calling it life struggles,
right.
We're going to talk about our life struggles section now. Like if the doctor said, or the nurse, tell us a little bit about your life struggles, right. Where are you with this? I think people would be much more open because that has more of a universal kind of normalizing feature to it. Whereas, your mental health. No, I'm good on my mental health.
Right,
yeah,
right. Yeah,
I don't know.
It should almost be like another part of the chart when you're doing the history of present illness or the family history or whatever it might be. There should be a section that covers, well, great, how are you really feeling, right?
Or just struggles, exactly, and just a couple little symptoms, and not calling it mental health.
Yeah, it might be what challenges are you facing, or what's going really well for you and what's not, right? Having those types of discussions.
I'll put a plug in for my friend Dr. Alan Tien. He is a psychiatrist with Johns Hopkins. He has developed a validated instrument that looks at 13 mental health parameters that can be completed on an iPad or computer or even a cell phone in less than 10 minutes in an emergency department environment.
Dennis, what does he call it?
It's called Behavioral Health Works. BehavioralHealthWorks.com from MD Logics out of Baltimore, Maryland.
All right, Behavioral Health Works.
What does it do? So wait, hold on. So you go into the ER, and it's a list on an iPad.
Correct.
And it's just asking the patient questions about.
Yeah.
Then what?
It comes up with a scoring mechanism on 13 different dimensions of mental illness, depression, anxiety, trauma, suicide ideation. I'm blanking on the others, but
right.
all 13 dimensions, and it provides the emergency department a baseline of not only the medical condition that they're looking at for the patient, but also the mental health condition, if you will, at that moment.
Oh, that's cool. So it's more just like sort of a baseline numerical value. These are the things that we need to kind of address. Interesting. Yeah. Cool.
Well, the thing that I think is interesting about mental health just in general is, look, what happens up here manifests itself physically somewhere in your body, right? And if you're in a situation where, well, great, you're depressed, well, here's this medicine. Like that's a medical diagnosis for a mental health condition, right? Or a medical acute approach to that condition. And I think it's really interesting to think about us as an integrated being where that works, our physicality works in concert with our mental health, and that's the way we should be considering it.
Absolutely.
Melissa, thank you so much for having a spot for me. I'm going to jump off and open up this spot for someone else.
Hey, Dennis, Dennis, before you leave, could you hear me?
Yeah, I can.
And that we talked about that yesterday. We talked with Dennis for a while yesterday. So good to see you again, Dennis. On that tool, you said that evaluation for mental health.
Yes.
Aside from the questions that are inputted in real time, does that pull in any other kind of data? If there's an HIE feed or medication history or retrospective data as well?
It would all be patient self-reported. So this is going to be an interaction between the patient and the survey questions that are part of behavioral health work. So it doesn't pull in any information from the electronic medical record or electronic health record.
Okay, because I would just see how that might bring more context to that situation, but I was curious what the actual input was. So thank you for that. Yeah.
Okay. Take care, everybody.
Bye, Dennis. Nice talking to you.
So, what's up, Mike? What do you think, Michael?
Oh no, this was great. I really liked the what I was going to go down the path was on the entrepreneurship angle in general, and so thank you for sharing some of both of your thoughts on the risk, the anxiety, the pivoting, if you will. And Jamey, was there a point where you actually said, okay, we need to pivot and figure out a different way to go about this? Can you think of a point that happened in your journey?
Well, I just remember, look, our telemedicine platform was born out of Language Access Network, right? So we were sitting there with a language services business, and it just occurred to us one day, we're like, well, we have this broadband network, and hospitals right now are facing, access challenges, cost challenges. You walk into a hospital, and there was literally a moment where we had walked into a room and someone was using our Marty unit and someone was using a telepsych device, and they were talking to each other over those two units, and it was like light bulb, right? Yeah. Why? That's a suboptimal use of the tech, right? Robots talking to robots, and it's totally unnecessary. And we said, what we really need to do is create a unified platform. We already have the network in place. We already have clients on the network. We already know they want to be sharing resources with each other. And we just happen, I think, to be at the right place at the right time with the right technology to help solve a lot of people's problems. Because what should really be happening is we should be doing something like this that's really collaborative in a care team approach for all of our patients. Like, how great would it be, instead of going to see the physician, if you said, you know what, I have my primary care doc here and my oncologist here and my cardiologist here, and we can all talk about what we should be doing together, right? It kind of gives me as a patient a lot more control over my care, and I can be more well-informed and make better decisions. And I feel like I'm being supported by a community of people instead of continually going in from island to island to island.
Yeah. And
how does your solution integrate with the best-in-class connected wellness platforms, if you will, that do a lot of this within disease management, care coordination, those kinds of aspects to healthcare, regardless of whether it's telehealth or not? And the other aspect of that would be the focus on eliminating care gaps, right? Yeah. Because when you were doing this, fee for service was not as threatened as it is now, right? Yeah. And so that value prop is so much greater now, but you have the foresight to be positioned as you are today. But I think the value prop is so much more powerful in a value-based purchasing world, right?
Yeah, and to that point, we are currently working with some leading academic medical institutions that have health policy programs on developing what we're calling new alignment models for telemedicine companies like ours, right? So is there a way for a company like ours to actually share risk in terms of, risk pools for patient lives and things like that nature? And well, yeah, if someone's ensuring limited English proficient and deaf and hard of hearing patients, and we can help improve their outcomes, which we're willing to stand behind, is there a model there that allows us to do that? And I think the answer there is yes. So we're going to be exploring that stuff coming up in the next kind of, 3 to 12 months and see if we can work with some of these academic institutions. I mean, at our conference at C3 Med, we had, Tom Main from Oliver Wyman speak. We had Mark McClellan from Duke. I mean, we've had, Jerry Kaminsky from UCLA. We're pulling on all those folks to help us devise the new models of the future when it comes to how are we going to pay for this service and what really makes the most sense, and what what's going to allow us to make the right profit margin, right? So that we're incented to do this, but take the amount of risks that patient outcomes are really the end result, right? Better patient outcomes, better patient satisfaction, and a better provider experience too. You know, we largely ignore the providers whenever we're talking about this, but there's a provider shortage in this country. And the more that we can do to bring great providers into the system, because we're providing amazing practice environments for them where they have all the right tools at their fingertips and they're feeling supported, the better off that we'll be. As far as the first part of your questions with the connected health platforms, you know, we're working on that stuff right now. We do not have full integration per se into an Omada Health or anything like that, who's doing population management, but those discussions are underway with some of those folks.
Okay. No, I think it's fantastic stuff what you're doing. And as I dig deeper into the world of telemedicine and how data analytics can help to bring more insights to that as well, we'd like to continue the discussions as we proceed here, Jamey. So thank you so much for attending today. This was great.
Yeah, no, my pleasure. My pleasure. Great to see you, Michael.
Yeah, you too. Melissa, it's always a pleasure.
You too, Michael. Thanks for jumping on.
My pleasure. We'll see y'all pretty soon. I think my daughter's calling for me.
Go 10 with that. Most important.
See you later.
All right, later, Michael.
So Jamey, I don't know if anyone else wants to jump on or if we should end, or, you know, because I want to be mindful of your time, but I'm glad that you were able to get on.
I'm happy I was able to get on too. I'm really embarrassed I was late. So sorry about that. But when clients call, you've got to be there for your clients. So sorry to everybody. And again, they weren't really familiar. They're like, a blab? What's that? I literally spent a few minutes explaining to them what a blab was while the blab was going on. So apologies for that, but happy to be able to join in the discussion. It's always a good one. And thank you, Melissa. And, you know, even though John's not here, thank you to him for setting this up. This is a great forum.
Yeah, it's very cool. And there was a lot of interest in you kind of, you know, you can tell people really wanted to hear what you had to say. Let's see. One more. Should we say, well, Liam's from Ireland, so why don't we give him a couple minutes and then we'll end? How's that?
Yeah, that works. Hey, Liam.
Hey, Liam.
Hey, Vanessa. Am I getting feedback?
Yeah, let's
Yeah, you might want to, should we maybe try again?
Okay.
I'll close you out.
Okay. Alexa.
While he's coming back in, I just want to bring one more thing up, Melissa, for James. I don't know if he was there earlier, but I'll put a link in the side there for a document that I have about the impact of telemedicine on insurance companies. I'm glad James is here. Jamey, if you weren't here before, I'm involved with a company that does telemedicine. Business model is extremely important, and I think fee-for-service is going to become less important as we go on. The health insurance companies have become tightly integrated with their analytics, and they are going to fund telemedicine directly because it will be cost-effective. So as fee-for-service diminishes, it's going to become less of a model where doctors are going to be saying, how are we going to pay for this? As it matures, I think it's going to be part of the equation, part of the business model.
Yeah.
Not an add-on. We're in this no man's land right now, part fee-for-service, part value-based. And it's very difficult to convince doctors when it's fee-for-service going to say, what's in it for me? I'm not going to get paid. But that's rapidly shifting.
I think it should be like other services that are out there that we all would purchase normally in our lives, right? We would have good transparency on pricing and how that works. But when I take a look at the insurance companies, I think one of the toughest things is like, you take a look at Medicare, for instance, right, which is how in a fee-for-service environment, most insurance companies are pricing their contracts with different groups. I experienced this in my ER and hospitalist and anesthesia group. We'd be negotiating with a company, and they'll be like, well, we'll pay you 80% of Medicare, or we'll pay you 1.25 times what Medicare is. And my answer to that is, how is Medicare relevant to the economic value of the service that we're actually providing? If we're helping reduce if you come to our emergency department and us treating that patient is less expensive than you going to another emergency department and our outcomes are better, shouldn't we be paid for that performance? And I think somehow paying for the performance of how a physician can actually do their job or how telemedicine performs is really how it should be done, right? As opposed to the fee-for-service environment and us coming up with a CPT code for a telemedicine visit. Hospitals currently pay for our service, and there are people in our industry who are lobbying for Medicare reimbursement. And I'm like, whoa, I don't think that's the right move. If we're providing value to the hospital, then there's a huge ROI on a service like ours, right? We can reduce length of stays in hospitals. We can improve patient outcomes. We can improve satisfaction. All those things are value-based in their orientation. And that's how we should be reimbursed for actually improving the situation and fulfilling a service. It shouldn't be based on how Medicare wants to pay for the service or anything like that. So I think us forging partnerships with insurance companies who can understand the value that we bring as a partner and helping them treat their patient populations from a population health standpoint is the way that we should be going. And that's the type of work we want to be doing.
I agree. I think Melissa would agree with me that Medicare is like the elephant in the room, you know?
Yeah.
Over 60, 65 senior population, everything seems to go along with Medicare because of the sheer weight and the size of Medicare and the sheer weight of the senior population, which is rapidly growing. For younger people, you know, they're working in the workforce, it's a different equation. It's a different equation. It's just a different players are different. The insurance companies are more willing to work with you than Medicare. Medicare makes something up, they put it on the plate and say, eat it or don't eat it.
Right.
Frequently people don't eat it. You know, doctors don't want to.
But they set the standards. It's funny because whatever Medicare does, eventually the insurance companies follow, whether it's regulation or payment. I mean, Medicare does kind of set the standard, but your point is it just sort of arbitrary? Like, this is what, you know, I don't know, like their fees and what I mean, at least Medicare, I mean, I don't know about you guys, but it seems like there's been a big shift in the last couple of years, and I'm sure it's the Affordable Care Act, but CMS seems to understand more what's going on. Like, if you look at their innovation, if you go to their site, they have their innovation division. I mean, there are some really interesting cutting edge projects that they're funding. And I mean, it's actually very cool to see. I mean, I think they finally have their head out of their proverbial, you know, I mean, they really understand what's going on now.
Yeah, look, I totally agree with that. If you look at the work at like Patrick Conway and his team are doing on the innovation side, it's actually really impressive. And I think they're moving in the right direction. And by the way, they haven't set out to be a price setter. They have a budget. They rearrange that budget. You know, they've tried to do innovative stuff on pricing with RVUs and things like that. But it's the insurance companies who are saying, you know what, we're using them as our baseline. And I think that's where the problem really is that, you know, they haven't, what Medicare can afford isn't necessarily the economic value of the service provided. And, you know, by the way, pricing transparency is a huge part of this issue, right? I mean, how can an MRI cost X in one place and Y in another? It's because those hospitals have different payer mixes. And so there's different cost shifting that occurs as a result of those payer mixes. And so to me, it's like breaking open that transparency. I think it was Steve Berkowitz at our conference who kind of said, transparency is the best thing to happen to healthcare since antibiotics. And I believe that. I mean, I think that couldn't be a truer statement.
You know what's really interesting is this. I only read one article on it. You guys probably know a lot more about it than I do. But that there's some movement where actually employers are going directly to providers and they're bypassing the insurance companies.
Right.
Like they did it with Boeing up in Washington, and they basically Boeing went directly to a provider group, and essentially they are kind of eliminating the insurance company. Have you heard of that happening? It was really sort of interesting because the whole idea, well, if we're going to pay for it, we're going to take on the risk ourselves and just eliminate the insurance company.
Yeah, and there are a lot of actually employers, right, who are basically, you know, it's their money and the insurance company just manages it. And I think there's a misnomer when you take a look at insurance companies' financial statements and you see, well, here's our premiums, here's how much we paid out for medical care. You know, what's beneath that is really their net revenue. And so when you look at insurance companies' margins, that's what you should be looking at. The insurance companies are there kind of saying, well, we have 3% margins, but their margins are actually higher than that once you get rid of the cost of the actual medical care, because they're not providing the cost of the medical care, right? They're paying for it, and they're managing that money, but they're not providing it. So I don't think that's a real income statement cost, if you will. And I think their margins are actually a lot higher as a result. That being said, some of the insurance companies are doing great work, right? There's a lot of innovation happening at United and Aetna and places like that, especially when it comes around to analytics, workflows, care coordination. And I think that's really what you're going to see the insurance companies really becoming in the future, are these care coordination organizations.
Good points. You know, I think the system is coming together in dribs and drabs.
Yeah.
What we build part of it, and then something else comes along, we integrate it into the system. Like with EMRs, we had to get the thing interoperable.
Right.
So the standard, it's coming along slowly for different reasons, but that's the beginning. With EHRs, they really couldn't get it going without federal funding. And that may be what it takes to get telemedicine going, although I'm not very much in favor of that. When we put the health information exchange together here in our county, it's pretty big, Rio. We decided from the get-go we would have a sustainable business model. We did not take any government grants. It took us longer to get it going, but we had some big anchor tenants that got the thing going. And that maybe will have to happen with telemedicine. We're having a cloudburst here. And that may be the same true for telemedicine as all the little different telemedicine companies. They're not even interoperable yet with EMRs. And I think they're going to have to become interoperable, and that data is going to have to be integrated into the electronic medical record.
Yep.
Like our company, we're in a silo. We're completely in a silo. Doctors can't see it. So that's another part of it. But there's a lot of telemedicine companies out there that are competing for the money. I don't know if they're going to be winners or losers. Some of them are getting pretty big. I don't know, but I think that the paying for it through fee-for-service is going to be a hard road to go, because doctors don't want to pay it for it, and insurance companies don't want to pay for it. Eventually, something's going to come from all this, because I think what the payers are going to find and the system is going to find is that telemedicine is going to be the house call of the future. Literally. We're not going to have house calls by doctors. We're going to have telemedicine people that are coming out to the home with a piece of equipment. They'll be in a zip code, and that's the day they're going to go around the neighborhood and do hemoglobins. Next time it'll be video for this, that, or the other, dermatology. But it can be organized by zip code. It can be doable if somebody's got the analytical mind to put this together, and then it will fly. It will fly.
Yeah, you know, it's interesting. To me, it's all about proper incentivization of human behavior, right? We have treated patients like children for so long, we're not even letting them pay the bill. You know, technically the insurance company pays the bill. And so they get to dine at the healthcare buffet, if you will. And to me, it's about how do we get that back in sync? How do we put the patient back in control of their healthcare budget and back in control of their care? And that's a combination of, you know, us, you know, saying, look, you pay the bill. You have a partnership with your care coordination company, which is the insurance company. They'll reimburse you for whatever these bills are, but you have a direct relationship with your provider. I think that intermediation between the patient and the provider relationship was actually pretty dangerous, because patients started to feel really entitled, right? And no matter what they did, they just expected us to take care of them. And I think we need to take responsibility for ourselves. If I'm drinking and smoking and doing all those things, God, you know, the cost of my care is probably going to be higher long term, and I need to think about that before I pursue those activities. So to me, it's about aligning interests and putting the patient back into control, to your point.
Mm-hmm. Well, you see that happening a little bit too with retail, where people who have really high deductibles it's almost like insurance on your house or insurance on your car. If you get into a little fender bender, you don't want to pay the insurance premium, you'll just go straight to the mechanic. It's a little bit like that with retail. Like, okay, if I go to the doctor, I'm going to have to pay $2,500. So I'll just go to a, you know, urgent care clinic, you know, and do it myself. You don't have this in Ireland. Lucky you guys, right?
I'm sorry. Can you hear me okay?
We're getting a lot of feedback from you, Liam, for some reason. Do you have a second window open or something? Because it sounds like one of those types of echoes.
It's 1 a.m. there. Everyone echoes at 1 a.m, Jamey.
Oh, there you go. Fair enough.
There.
Let's stick this in there. What about that? Is that any better?
Oh, that's magic, man. It's like you're right next door.
Yeah. I often wonder, I'm sorry I'm late to this discussion, but I often wonder if we were designing a health system from scratch. I mean, I know the US system just seems to me incredibly complicated.
Yeah.
And the National Health Service, which I worked under, is not perfect either. But Winston Churchill once said that democracy is not a good system of government except when you compare it with everything else. And I think in many ways the NHS is similar. It's not a good system of healthcare except when you compare it with anything else, where
Right.
there's general
It's all relative, right?
taxation and everybody's all healthcare costs are paid out of that. I mean, if you're taking a nihilist view of healthcare, there should be no healthcare at all, because most benefits in terms of longevity and quality of life are nothing to do with actual medical care. They're all to do with public health initiatives like sanitation, better food, better clothing, electricity, education. I remember reading a figure, although I can't give you the reference to it, that in terms of longevity, actual medical care, all the great medical apparatus, all the machines, all the drugs, only contribute 10% to actually healthcare. All the rest is more to do with standard of living.
Diet, exercise, right?
Yeah. All those things contribute so much more. I mean, coming from an NHS background, I believe very firmly that healthcare is a human right, not something which should be paid for. That those who are unfortunate enough to suffer from illness, the rest of the community should support them. But along with that comes a responsibility to use that right responsibly. Not to smoke, not to indulge in dangerous behavior, not to use the medical services trivially, and not to bung it up with worried well instead of the really sick people who need time. I often wonder if we started from a very first design a health system, how would we do it? Now, probably the last one we would end up with is the one you have in the US, which just I constantly find bizarre and befuddling and confusing. At least the NHS is relatively simple. We don't have that layer of bureaucracy of insurance companies, which again seem to be just complicate things even further. But it is such a difficult subject, and there are never going to be any easy answers. And the actual probably nihilist, evolutionary, Darwinian solution would be not to have any healthcare at all. Just you take your fucking chance and you look after yourself and you make sure you don't get sick. Sorry, have I talked enough?
I think people definitely behave differently if we all share that.
Vanessa, I'm so sorry.
What are you sorry about? It's awesome.
Yeah, I mean, it's a great comment, Liam. I've often, we would sit down with, Melissa was at our conference in Vegas. We literally would sit down and we'd be like, what if we burned the whole system to the ground and rebuilt it back up? Like, what would that look like? And you start to design really cool things, but then you realize, you can't build a new system on what is a very difficult governmental foundation to navigate. And until we in the U.S. have figured out how to fix our government, it's going to be very difficult for us to have a sea change fix in healthcare, right? Because the government is the lion's share of our healthcare system, even though we have a lot of privatized insurers and medicine and everything else. My theory has always been that the insurance companies should be more like utilities. public utilities, because that's really what they are. If we consider healthcare a public good, then insurance companies should be a public utility and should be regulated as such. And I'm not sure they are today, and I'm probably not making any friends at the insurance companies by saying it. But they're doing a lot of great work, but they also are just as much a part of the problem as they are a part of the solution, to your point, Liam. And so it's really a question of figuring out, do we have a powerful enough political lobby to say, you know what, we need to have a dramatic change, and this is what that dramatic change is going to look like, and how do you affect that change with a population of 250 million people?
Well, I would argue, Jamey, that it's already happening to some extent. And really, the whole system is going more toward a Kaiser approach, where you have the provider and the insurance company are one. I mean, that's actually where all of value-based medicine is going to some extent. I mean, if not directly provider is the insurer, it's sort of, if not literally, at least figuratively, they're one and the same, because that's what makes the most economic sense.
Yeah.
So if you're going to continue to have for-profit companies as the payers, that's really where they're migrating toward, really kind of managing sort of populations in a much bigger way. It really looks more like Kaiser.
It's interesting that you say that, Melissa. It's kind of like when you take a look at industries, they go through these cycles, not necessarily a boom bust, but of centralization and then decentralization only to centralize again, right? Or consolidation, bundling and unbundling, right? I think there was a great blog post on that was going around on Twitter on bundling and unbundling. And, that's very much what's happening in healthcare right now. So I think you're going to start to see the bundling of more services together. And that bundling is going to be the vertical integration of insurance companies with providers. And then again, you might see an opportunity where someone says, oh, you know what, I can do that better. I'm going to unbundle this one part of the healthcare ecosystem and see where it takes us. But it's a really interesting question to have answered.
I just feel, James, that the industry model does not work in healthcare. I mean, a patient is not the same as a client.
Yeah.
And in industry, you can count things, but many medical things, the things that can be counted aren't worth counting, and things that are really important can't be counted. It's like time with patients. I mean, often, for example, in private medicine, which I have some familiarity with, the money is in doing things to patients. It's procedures. It's take them into a theater, stick my probe up some orifices. Then you need nurses and anesthetics and drugs and all kinds of stuff. Whereas often the smart thing to do is sit overnight, or say come back in a week. But there's no money in that. Money doesn't respond to that. I don't think the healthcare model responds in the same way it's the industry model. And I think that is one of the reasons that the US healthcare system has become so complex. Like there's no payment recognition for what we would call in medicine masterly inactivity, doing nothing, and saying coming back in a week and let's see how you are.
But Liam, I think that's shifting, because again, a Kaiser, they take a much more conservative approach, meaning they're not getting paid per service. That's really the fee-for-service model, but actually value-based care is not. It's sort of, here's the number we're going to get for you, for an entire year. So we're not going to spend it unless we really need to.
Right.
But I'm with you. I mean, I don't think many people would argue. The problem is how do you change it? So, but yeah, no, I hear. I mean, you could argue the entire pharmaceutical industry. A lot of things, they want you to take them in a chronic way, when in fact that might not necessarily be the best way to go. Hey, Jamey, I'm really mindful of your time. you guys need to sign off soon? Probably.
You know, I was late. I'm willing to hang out for a little while longer if people want to continue the discussion. I'm fine with it. This is a good dialogue. I love this type of stuff.
Okay, well, it's whatever. I just wanted to be kind of mindful of everyone's time.
Yeah. Liam, I don't know if you're familiar with ZDog MD, but he gave a presentation at our conference a few weeks back, and you know, his quote, and he had a picture of kind of Winnie the Pooh up at the point in time at which he said this, and he's like, we need to be in a healthcare system. That's what I was searching for on Twitter because we had posted on it. We need to be in a healthcare system that does things for poo, not to poo, right? And that was kind of to your point, is we need to be doing things for people, not to them. And it needs to be much more personal, much more customized, and much more about what does this person need, not necessarily what they want, right? Because there is a culture in our country, and I don't know about Ireland, where a patient comes in and they've got their kid and their kid might be sick. And, you know, we say, well, look, give them antibiotics even though they don't need it because that'll give everyone peace of mind. And that's not necessarily good medicine, right? It's not necessarily the right thing for the patient. So, you know, those are the types of things we need to consider. I'm totally on board with you.
You're so right, James. And I'm retired about 5 years. But I discovered something in the last 10 years of my practice that it was much more important that I liked my patients rather than that they liked me. I mean, it's not a doctor's job to be popular. Often we have to say things and do things which conflict with the patient's expectations. And I think we have to reach a stage where patients appreciate their responsibilities as well. I mean, the antibiotics example you mentioned is the perfect one.
Yep.
I mean, and for example, in the NHS, I was the patient's doctor. If I didn't give them antibiotics, they didn't get antibiotics, that was it. But in any kind of private system, that's not going to work. The patients are going to go from doctor to doctor until they get what they want. After a couple of days, the kid gets better. The patients attribute that to the antibiotics, and the vicious circle is propagated even further.
Yeah.
We have David, do you want to jump on? Anybody else want to jump on before we close out here?
Yeah, Liam, if you ever get to the States, let me know, man.
James, I'm going to tell you something which Melissa knows. I'm a recovered. The reason I retired from medicine early and became a writer full time is because I'm a morphine addict and I have a drugs conviction, which limits my availability to travel
globally
to the States. Unfortunately, my son Jack is actually working in Washington D.C. at the moment, so I'm applying for a special waiver to be able to go and visit him. So I would love to do it.
By the way, thank you for sharing that. You know, I was out in Ireland about a year and a half ago, 2 years ago. It was absolutely beautiful. We were out in Dublin and then County Cork and a few other places. It's really a glorious place.
Yeah, the West Coast is fantastic. I was just there the weekend, seeing the wild Atlantic sleeping in. It just takes all your stress away. Melissa is coming someday. Someday.
Back to homeland. Exactly.
Yeah.
There you go.
Yeah, okay. I'm going to say good night.
All right,
Thanks very much.
Liam, Liam, before you jump off,
yeah,
I didn't know that. So really, you can't travel to the U.S. Is there a time frame on it, like for the next year, or? I
applied for 3 years ago. My son Jack was volunteering for the Obama in,
Right.
that's supposed to be 2012, and it was refused then, and I was told to apply again. So now he's back for a year. I may apply again, but it's a very difficult, onerous process to go through. But I respect it. You know, I did one of the ultimate medical transgressions. You know, we're given this responsibility for these incredible, powerful drugs, and I reneged on that responsibility. So I have to accept the consequences.
Yeah, but there needs to be forgiveness at a certain point, and
well, I hope so.
Yeah.
I mean, I wouldn't like to give the impression I'm a sad guy. I'm not. I had a great night tonight. I was out with a couple of mates. There was a traditional session going on. We played a few beers. I'm a happy, horny guy, but there are consequences to our actions.
Absolutely. And you know what? All Irish people, there's a little vein of sadness under the current. So it's all good.
Yeah.
I hope you get over here one day.
Yeah, so. I'd love to see it. Love to see it. Okay.
All right.
Good night, Melissa. Good night, James.
Yeah.
Good to talk
Take
to
it
you.
easy, man.
So, Jamey, thank you so much for everything. And I'm sorry we took so much of your time, but I'm so glad you were on. This was awesome.
No. Look, my pleasure. Again, sorry for being late. I will do this any time that you want and promise to be on time the next time. This was awesome. What a cool experience.
I know, it's super fun, isn't it?
Yeah.
I'm glad you.
You know, we often, when you're at work, you don't sometimes get to take a step back and have these discussions because you're focused on getting project A, B, or C done. So the opportunity to take a step back and actually, wax philosophic about healthcare is a unique opportunity.
Yeah, remember I was saying that in the email, that in a way with Blab, and especially like if we were to stay on, then what ends up happening is that a bunch of random people start coming back. John would come back in. We once had a Blab that went on for 3.5 hours.
Oh, really?
And, yeah, but it was really funny because we took screenshots at certain points. And at the beginning, it was very formal and everyone was sort of doing what they, and then what happened by like the third hour, people had gone off, they'd come back in, they'd gone off, and there were like random people. And it was the last shot, we were laughing hysterically. I mean, it was like a party. But it's like if you kind of go with it, that the conversation sort of takes on interesting twists and turns, and it feels more like being in a college dorm, where.
Oh my God, that comment really resonates with me. Those were honestly, some of my favorite times at night were staying up till 2 or 3 o'clock in the morning, talking about how we were all going to change the world, right? And the things we would do once we were finally out in the real world. I mean, that hits home.
Yeah, no, I mean, that's kind of what happens. I mean, the tricky part is that when you have like 4 people on, it ends up, sometimes people talk over, but you kind of get into a rhythm, and then there's like, it's very, very cool what happens. Like, just, especially if you get 4 people who are sort of somewhat philosophical and interested in sort of going where discussions go. It's like the best thing ever, actually. It's the kind of thing. And also people that you wouldn't normally, like, you're in LA, I'm in San Diego, Liam's in Ireland. Like, we're not going to run into each other at the pub, but
right.
It's very cool. So yeah. So
I'm super grateful. So thank you for thinking of me and having me. And anytime you want to do this again, you just let me know.
I will. And John and I, sometimes we do the late night blabs because those are fun, like the 9 p.m. and later. So we'll kind of ping you and say, hey, we're on. You can come hang out. So
yeah, look, that totally works for me because the kids are asleep at that point in time, and I'm usually doing a little bit of work anyway. So I'd be happy to take some time out for the late night blab.
Yeah, good. Okay, we'll work on a late night blab next time. So anyway, talking to you. So take care. Bye, everyone, and thanks for joining us.
Yeah, bye, everyone. Thanks for the time today.
Take care. Bye.
Take it easy.